Good evening, everyone. My name is Gopika Vinayachandran, and I'd like to welcome you all to this discussion about pursuing the MRCS route after MBBS or as an MBBS graduate from India. And before I start, I'd like to thank all of you for attending today, first of all. And I'd like to thank Mortimer Green and everyone at Mortimer Green, including Dr. Vinayakarangan, Suprabha, Ankur, and anyone and everyone there for giving me this opportunity to talk to you. So without further ado, we can start talking about, we can start the discussion on the MRCS pathway after MBBS and the major considerations that we can take as an MBBS graduate while we pursue this particular pathway. So this is a quick slide about what I'm aiming to cover today. And the first thing that I'll discuss, it's the exam itself, and give you a quick, I'm sure you know at this stage, if you're sitting here in this webinar, you have some idea about the exam itself, but I'll quickly brush through the main salient features. And I'll also talk about whether at our level, whether we can give the MRCS. First, if we're eligible to give the MRCS and whether we should even be considering it. Secondly, I'll be giving a bit of a comparison about the exam, the two main pathways that we have after MBBS from India, which is one, the most commonly used route, which is the Plab pathway. And I'll be comparing it to this MRCS pathway, which a lot of people don't usually follow. The next thing what we can talk about is the major considerations that we can think about while choosing the MRCS pathway. Sorry, just one second. Hi. Yeah, so the major considerations that we can think about while choosing this MRCS pathway as an MBBS graduate. And I'll also be talking about how we can prepare, how we can maximize our chances of getting through as an MBBS graduate. I'll also be sharing my personal preparation strategies. I'm not sure if that's something that you would take, but it might help. So I'll share my way of preparation as well. Then after that, we'll talk about how we can approach the UK surgical pathway once we've got the MRCS degree. So the surgical pathway in the UK is very different compared to our Indian one. So I'll talk about the usual training pathway, and following which I'll talk about the other options. So if you don't, for some reason, get into the surgical pathway, you have other options to complete your surgical training or surgical, get the final surgical degree in the UK. So I'll be covering that as well. And following that, I'll be talking about, as an MBBS graduate, how we can maximize our chance of getting into the system, the NHS system, how we can make our portfolio, our CV, very attractive to the NHS employers, and also how we can maximize our chances of getting into training itself. Finally, I'd like to end this discussion with telling you about what life is like as a junior doctor in the UK. So just so you know what you're expecting when you come here. So to start with, we'll discuss what the MRCS exam is. So first of all, it's an exam which gives you the membership to the Royal College of Surgeons. There are 4 Royal College of Surgeons, and this exam is a postgraduate diploma which lets you into one of the 4 colleges, the college of your choice, essentially. So it used to be that each of these separate Royal Colleges had exams of their own, which is very different. But now it's a single unified exam, there's not a lot of difference which college you apply to. So at the beginning of your application, you'll have to choose which college you're applying to. And although you are applying through that college, the exam itself is not very different. The aim of this exam is to let the general surgical community know that if you're a holder of this postgraduate diploma, you have the necessary knowledge, experience, and competence to, equivalent to that of someone who's completed CoTraining here in the UK, and you're ready to progress to higher specialty training. Like, for example, your general basic surgical training is complete. or you have the basic surgical skills and you're ready to go into specialty training here in the UK. This particular website that I've given here gives you some details about the exam. So if you've not already taken a look at the exam or read about the exam, this is a good place to start. So these are the 4 colleges that give you the MRCS degree. You have the Royal College of Surgeons of Edinburgh, England, Glasgow, and Ireland. Like I said, it's a unified exam for all 4 colleges, but you apply through one college, and you can actually choose to apply Part A through one college and Part B through a different college. You just have to send in separate your primary medical qualifications separately. But yeah, so it's a unified exam for all 4 colleges. But there are some small differences. Whether that is important or not, it's up to you. But small differences, like if you're writing from India, I believe that RCS Edinburgh has more centers in India rather than England or Ireland. So if you want to complete all parts in India itself, there probably are more centers in India, more frequent exam centers in India for the RCS Edinburgh College. So you might want to choose that. But if you're planning to work in mainland England, then a lot of people here will be members of RCS England. But essentially, finally, it doesn't really matter which college you're a member of. The next thing is how frequently the exams come. So there are usually 3 diets in a year, one early in the year, one mid, and one towards the end of the year. So the implication of this is that I've had a lot of people ask me, so can you finish all of this really quickly? It is a faster pathway, in my opinion, because there are 3 exams or 3 diets in a year. Even if you plan properly and give the first exam in Jan or at the beginning of the year, you can aim to complete Part B at the end of the year, and you will finish the whole process in about a year's time, which is equivalent to a preparation year for NEET, or which is probably less than the amount of time you're spending for Plab. Then this is now an exam given in. So coming back to the presentation. Yeah, so the online exam is given in partnership with Pearson VUE. Don't worry about this because once you apply, once you've submitted your application, at the time you will just make sure that you check your mails regularly, and the Royal College of Surgeons will keep sending you emails with clear details and clear instructions on how to go the next step for applications and how to secure a seat at the center, everything. So you don't have to worry about it. The exam itself, the MRCS exam, has 2 parts for those of you who are not familiar with it. So the first part, or Part A, is a written paper, which is a 5-hour paper with 2 separate sections, applied basic sciences and principles of general surgery. It sounds very complicated. It sounds like maybe it's something that more senior people who have experience with general surgery should write, but that's not true. I'll explain in a second. So Part A is a written paper. Part B is an OSCE. I'm sure you've all written or all faced OSCE examinations during your final year, or you will, or clinical examinations have for a long time been conducted as OSCEs in our colleges. So we're familiar with, it's essentially the same thing. It's got stations with examinations, history taking, Viva stations, etc., which I'll be coming to in a second, and it's very straightforward. So the next main question that we have to deal is, can I give the MRCS exam? So as an MBBS graduate from India, whether I can give the MRCS exam. First of all, short answer is yes, definitely we are eligible to give the exam, because the only requirement for the exam is that you have a primary medical qualification that is acceptable to the GMC or MCI, Medical Council of Ireland, which is true for most of our colleges in India. If you have a doubt, there's this site. If you can just follow this link, which is basically to the World Directory of Medical Schools, it tells you if your college name is on that list, then you're definitely eligible to write the MRCS exam. So your primary medical qualification is only thing that's required. Previously, it used to be that higher surgical degrees or 2 years of surgical experience is essential, but that is no longer the case. If you have an MBBS, you can write the MRCS. Whether the second question is whether or not you have enough experience or whether you have the know-how to pass the exam. I have passed the MRCS exam as an MBBS graduate. I know a lot of others who have. This is a less known pathway, but it's not an impossible pathway. It takes a lot of preparation, but in the long run, I believe it definitely is possible to crack the MRCS exam as an MBBS graduate. So yeah, that's to answer the question. Yes, we are eligible to write the MRCS. Now let's go on to a very confusing question to MBBS graduates, something that is asked of me very, very frequently, whether we should give the MRCS or the Plab route. So to answer this question, it's a very difficult question. It's not a straightforward answer. I've compiled a few things which we can consider while thinking about MRCS and Plab. MRCS itself is a higher level qualification. So basically, in the surgical pathway in the UK, the MRCS comes as a postgraduate diploma, whereas the Plab is a licensing exam, which is basically at the level of your MBBS final exam. So that being the case, more is asked of you as in an MRCS exam from a surgical point of view. Plab is more for, as I said, for graduates of medical schools. From the surgical point of view, it is not that extensive. But I have sat both the exams, the MRCS as well as Plab Part 1. I'm not sure about Plab Part 2, but Plab Part 1. And I felt that the difficulty level of the examination, the Part 1s at least, is fairly similar. Even though the application level of some of the questions is higher in MRCS, somehow the overall difficulty in terms of time management, in terms of the requirement of preparation, is not very different between Plab and MRCS Part 1. And even if you put in a little bit of effort in preparation for MRCS, it might actually be worth it in the end. That is my personal opinion. But to give you the comparison, yeah, MRCS is technically a higher level qualification and it's a postgraduate diploma. The second point is that the MRCS actually requires a full medical qualification. You need your MBBS certificate to apply for the MRCS. So at the time of application, even if you do, some of us, I had the same problem. I had completed my internship. I had my MBBS completion certificate, but I didn't have my degree in hand because the convocation hadn't happened yet. But at the same time, if you submit a letter and your provisional certificate, temporarily they'll let you apply for the MRCS. Later on, you can update your MBBS certificate. But on the other hand, for Plab, you don't really need to complete your internship. You can write the Plab Part 1 and apply for Plab Part 2 as an MBBS final year student, or as soon as you complete your MBBS final year while your internship is going on. So that in that particular way, in terms of actually preparing in advance for a UK shift, Plab might be slightly better. It gives you a head start. The third point that I want to stress is a logistical or a planning wise important one, is that MRCS does not need IELTS or OET at the time of the exam. You can directly book the exam. Whereas for Plab, I am sure some of you, if you're following the pathway, I know that you know that to even book the first step of Plab, you'll need an IELTS or OET score. The thing about this is, the IELTS or OET is only valid for 2 years, I believe. So by the time, if there's any delay in your Plab, course, to get seats, or if you don't clear it the first time, it's very possible that your IELTS runs out by the time you reach your GMC application level. But for MRCS, you can complete your whole exam And only when you know for sure that you're ready to apply for GMC, you can apply for IELTS or OET. So that might give you a bit of a, it might give you less stress, and it might save you money in terms of writing IELTS again. But again, this is entirely depending on how a personal situation goes, how your personal situation is at that particular time. So just a consideration to keep in mind. The fourth point is that Part A and Part B for MRCs are available internationally. So if you want to write the whole exam in India, MRCS is the only way to go, because Part B for Plab is only available in the UK. So I will answer all these questions at the end of the exam, because at the end of the presentation, just so that we can have the continuation of the presentation. So if you want to keep asking questions, please do. I'll look at them after the presentation and answer. If not, if you can just wait till the end of the presentation and answer all the questions one by one. All right, thank you. So basically what I wanted to say is Plab Part B or Plab Part 2 is only available in UK centers, London and Manchester. So that's an additional thing to consider in terms of cost, visa, coming to the UK, getting seats. So that's just logistically one thing to consider. The fifth difference is, I don't mean to scare you, but statistically, MRCS has slightly lower pass rates, not slightly, but lower pass rates compared to the Plab exam. And Plab has higher pass rates. I will be talking more about this in the next slide. Yeah. And the sixth difference is prep time. So these are figures that I actually got from some research online, and what generally people say. MRCS, again, this depends a lot, differs a lot from person to person. But the Part A for MRCS is about 1.5 to 3 months of dedicated preparation. Dedicated, by what I mean by dedicated is not working, like not working full time, then coming home and reading for maybe half an hour, 1 hour. I'm talking about sitting down and preparing. 1.5 to 3 months seems a little in excess. I would say about 1 to 1.5 months is what I would say if you have a good base. It depends on where you're starting out, but yeah. But for Plab, for Plab, same thing, 3 to 4 months. But this is not dedicated time. This is with work that I found. So around 3 to 4 months along work. So essentially, there's not much of a difference in preparation. But I think MRCS Part B requires a little bit more strict preparation. I'll come to that in the next slide when I'm talking about preparation. Okay, so to talk about pass rates, I said that MRCS has lower pass rates, which is evident in the slide. So Plab has pass rates at about 60 to 70% for both Part 1 and Part 2 equally, which is not a bad pass percentage. If with some good preparation, you can easily pass Plab. But for MRCS Part A, you can see pass rates is as low as 30 to 35%. This is figures from, I think, 2020 to 2022 survey. So pass rates are a little low for Part A. But this is not something that we can't overcome with preparation. But Part B has higher pass rate, probably because people who actually pass Part A are writing Part B, and the exam itself will, if you're spending so much money to write the exam, you will essentially prepare. And with preparation, it's not a difficult exam to pass. So I will talk more about it. But yeah, essentially, I don't mean to scare you, but slightly lower pass rates for MRCS, especially Part A. Okay, this is a very important slide in considering the exam, and I'll tell you why. This is so we're comparing the cost of the exam itself here, and obviously as MBBS graduates, it's something that we would definitely consider while picking the exam. So for Plab, the total cost comes around 1,189 pounds, which is close to 1,20,000 in Indian money. Plab 1 itself is cheaper, whereas Plab 2 is slightly more expensive. Whereas MRCS Part A is double the amount of Plab 1. It's about 500. Currently, it is 578 pounds, which is around 60,000 in Indian money. And MRCS Part B is around 1,045 pounds, which is close to just over 1 lakh. So total comes around 1,70,000 for the MRCS exam. So it's not as straightforward because there are other factors we have to consider while giving the exam. So even though Plab comes slightly cheaper in terms of the exam fee itself, one thing to consider is Plab 2 only has UK centers. So if you're writing the second part in the UK, you'll have to think about visa, travel expenses in the UK, staying, accommodation or rent, food, everything itself it's a huge amount of money that you're talking about. So just considering the exam fees itself is not enough. But of course, if you have friends or family in the UK and those expenses are not as much of a concern, then definitely Plab is a definite consideration. So in terms of MRCS, like I said, the exam itself is 1,625 pounds, the total fees. But another thing that we have to consider is it's a slightly lower pass rate. So in case we do not get through the first time, then if applying all over again for the next attempt, it's a significant expense in itself. So we have to think about both of this while thinking which exam is best for us. Sorry, excuse me. So considerations before choosing the MRCS exam as your gateway to the UK. So these are on the left, these are the main things that that we have to keep in mind while thinking about choosing the MRCS. The first thing is a career plan. By this, I mean, do we see ourselves in a surgical career? If not, then the MRCS will not be really giving you any benefit over a Plab exam. Because when you come here, if it's surgery that you're looking for, then having the MRCS will give you preference over people who don't have MRCS in any surgical job. It will give you, if you have the MRCS, your employers will expect a particular standard of you and know that you will have that standard. So it definitely gives a boost in terms of a surgical career. But if you want to do, say, internal medicine, or if you want to do pediatrics or any other thing, if you enter one of those jobs, then MRCS is not of much use because it is a degree, it will give you GMC registration, but in terms of applying for a job, it doesn't mean much. I know it's a very basic thing. I know most of the people attending today's webinar will be thinking of a surgical pathway, but just to state the obvious, your career plan, if it is a surgical one, then definitely MRCS is of consideration. The second thing is surgical experience. Although there are lots of benefits to writing the MRCS, it is an exam which is given by say someone who's done CoTraining in the UK. So Part A is mostly for somebody who's just gotten into CoTraining, possibly at the level of MBBS graduate, so it is something we can crack. But Part B requires some sort of surgical experience. The exam stations itself talks about or covers surgical surgical examination, like examination of swelling, examination of the abdomen, things that we have done as an MBBS graduate or during our MBBS studies, but say abscess drainage, catheterization, knot tying. So these are suturing. These are all things that we know, but we may need a bit of familiarity with it to perform well in the exam. So a bit of surgical experience really does go a long way in how we perform in the exam itself. It's not something that we can't make up with practice, but having that experience will really help. This is just my opinion, but how much of surgical experience, how skilled are you in basic surgical skills like knotting, suturing, abscess drainage, catheterization, gloving, donning an apron, everything, basic surgical skills. really goes a long way. Then considering the difficulty of the exam itself, like that is something that we've covered. It is essentially similar to the surgical exam. So even though the difficulty of the exam is more or less the same, it's heavy on surgery compared to Plab. So if you have that surgical experience, it helps. And the cost is something we've discussed as well. The main areas that we need to consider in choosing this exam, especially from a cost perspective, we have already discussed. And the job prospects. Like I said, we want to think about what level we are applying to. So if you're very, very fresh from MBBS, you might want to think about starting foundation year jobs, in which case MRCS is really not necessary and you have time to prepare and give the MRCS exam later on. But if you've maybe done a year or two after your MBBS graduation, then maybe you might want to think about a more senior role like CT 1 or 2 equivalents, SHOs, in which case an MRCS will actually help. So what kind of job prospects you're applying to in the UK? And finally, the importance in training pathway. Like I said, to get into CoTraining, you don't need an MRCS. It used to be that in the previous, maybe 1 or 2 years ago, MRCS Part A had some weightage in trying to get a training number, but now that's been taken off. And now you don't need an MRCS. But to get into specialty training, you definitely need an MRCS. So at some point of time in your surgical career, you need your MRCS. So it's about getting that exam out of the way or leaving it to a later time so you can prepare more and give it when you're more ready. So these are the considerations that we can think about while choosing the exam, before the exam. So quick discussion about pros and cons, which most of the points we've already covered. First one, obviously, writing the MRCS now gives you GMC registration, and MRCS being an exam we have to tackle later on in our surgical career itself. 2 birds with 1 stone. You can entirely skip the Plab exam to get the GMC registration. So yeah, essentially it skips an exam. It skips the cost of an exam. It skips the preparation of an exam. But at the same time, skipping the cost is provided you pass the exam in the first try. Second point pro is that it's faster. Currently, after post-COVID, I hear that Plab is very slow. Like the Plab pathway, if you don't have cancellations, essentially, it takes a long time. It takes up to year and a half to actually get the Plab seats. In which case, you can finish the whole MRCS exam in a year if you prepare well. So it is a faster pathway, essentially. The third is, like I said, if you have an MRCS, you will be given preference over somebody who does not have an MRCS in the same set of applicants. So you do have a bit of a benefit in the job market, and people will often ask you, oh, do you have an MRCS here? And if you say yes, and then they automatically assume you have a basic level of competence. But even though it gives you an added benefit in the job market, I want to stress that it is not necessary for a junior level doctor, as in a co-training job or non-training posts, even at a slightly higher level. So it is not necessary, but it does give you an advantage. The fourth point is, like I said, it's one less exam to, if you do it now at home while you're preparing to do this post MBBS coming to UK, that exact area is a bit of a stressful situation. You need to figure out what you're doing. So if you get this exam out of the way right at the beginning, it's not something, you don't have to worry about it once you're here. You can actually work on improving your portfolio and getting into training. So from a practical aspect, having the MRCS done and dusted will help you out. That's what I did. It really helped me out. So I'm just, it's just a food for thought. And finally, it makes you eligible for higher posts. This entirely depends on your level of experience in India and your confidence. But as an MRCS graduate, you're even eligible to apply to a registrar post, as in you can entirely skip the core training, CT 1 and 2, or CT equivalents 1 and 2. You can apply as a registrar, which is essentially equal to I wouldn't say senior resident, but yeah, a more senior post in the NHS. But obviously, with this more senior post comes more responsibility, and your decision making has to be strong. You have less chances of making a mistake. You're responsible from a legal point of view. So obviously, it gives you an opportunity to apply for higher posts, but it also gives you that stress. On the con side, for MRCS, like I said, if you're not sure about a surgical career, it might not be the right exam to commit to. The second thing is, again, something that I've covered. If you're very junior, if you just post MBBS, I know that just after MBBS, my suturing wasn't that great. I know that my surgical skills, say if I wanted to do an excision or an incision and drainage of an abscess, I wasn't the most confident. So if you have no skills, no surgical experience whatsoever, and your skills, you're not very confident in your skills, then Part B might be slightly difficult, and you might need some more preparation before you give the Part B exam. It's not impossible; you can definitely do it, but it just needs some more preparation. And like I said, slightly more expensive, especially if you don't clear in the first chance, just to consider. And finally, low pass rates, and it is only a benefit if you pass the first time around. Okay, so let's come to the million-dollar question of how should I prepare for the exam as an MBBS graduate. It's a bit of a difficult question to answer as well, but let's take it step by step. So first, what is the Part A, or what consists of the Part A exam? Is basically the Part A exam is a post-foundation. It's aimed at post-foundation or CT1 students. So essentially, it's not very different from where we are at now. Quickly to discuss with you about what foundation and CT1 means. Here in the UK, your surgical pathway is basically you have the medical school, 5-year course, undergraduate course, just like we have in India, followed by 2 years of foundation, which is basically rotations like our internship. They have rotations in different specialties, and you can choose. If you're interested in a particular specialty, you can choose to spend more time in that specialty. You can choose to take electives and tasters in that specialty, but it's basically a 2-year rotation. F1 is the first year of rotation. You're provisionally registered, and F2 is the junior most year of a qualified doctor. So as an F2 level, you're qualified. And after F1 and F2, you can either choose to do one more year of F3 or to prepare and improve your portfolio before you apply for CoTraining, or you can directly apply for CoTraining, which is a national application. So CoTraining, I'm talking about surgery. In CoTraining, certain surgical specialties don't have CoTraining. It's a run-through training directly into specialty. That is specialty training 1 through to 8, whereas some specialties do 2 years of CoTraining, CT1 and CT2, followed by 6 years of specialty training. So this exam, MRCS exam, is aimed at the beginning of surgical training, which is essentially right after foundation, or if you don't essentially have to write it in foundation, you can do it in the first year of training as well. So it is not very different from where MBBS graduates from India are. So Part A is definitely doable for us. It is a 5-hour exam. So it's a single day exam with has both morning and afternoon papers. The first paper, the major paper, is Applied Basic Sciences, which is for 3 hours. And the second paper, the afternoon paper, is Principles of General Surgery for 2 hours. Applied Basic Sciences has the major basic, it covers the basic topics of anatomy, physiology, pathology, pharmacology, microbiology, and imaging. But in my experience, it's been very heavy on anatomy and the first 3, anatomy, physiology, and pathology in that order. Principles of General Surgery is the second paper, which covers the more, it covers other trauma, critical care, urology, neurosurgery, all of the other surgical branches. But as you prepare for the exam, as you, read more about it, you will definitely come through into a more detailed account of what these exams cover. But this is a quick overview about the Part A exam. And for me personally, what I thought was the major determinants for succeeding in this exam is first one, familiarity. So it's like any MCQ questions, like if you're prepared, I'm sure you've all prepared for your NEET, UG, APMT or INISET. For any MCQ exam, the most important thing is familiarity. Especially because time is of the essence, knowing what a question is asked or knowing what you're asked of in a question is very important. So practice, practice, practice. Do as many questions as you can as early on as you can. And when you practice, you will see the high yield topics. So any exam covers certain topics, or any exam has favorites. So in terms of the Part A in MRCS, I found that, say, for physiology, acid-base balance, the renal physiology, respiratory physiology, especially the gases, acid base, and then ventilation perfusion. All of that is very, very important, or favorites of this particular exam. So if you find the high yield, so as you practice, you will understand the high yield topics. So focusing on them will actually get you a lot of points. Then third thing is dedicated revision time. So it's not important just to do as many questions as possible, but to have a proper revision plan. So the last 2 weeks, I would say last 1 to 2 weeks, I would say dedicate to revision, because it's not just important to do the questions, it's important to have them at your fingertips while you give the exam. So certain concepts will need revision, especially the, say, anatomy, especially some pathology, some fact-oriented will need revision. So I would say have some dedicated time for revision. And time management, like with any exam, time is very, very important. There is no way that there's no point in having the knowledge if you can't give it in a short amount of time. So time management, and finally the preparation resources. So most resources, any resources that you use while you prepare for the exam, will cover the essential topics. But it's also about using the previous year's questions. I found that previous year's questions were really helpful in my preparation. Not just that, the preparation resources will have the questions, but it's about how you use the resources. Like I said, some of them will have ways in which you can come back to the questions that you've lost, or flag the questions that you need to revise, or so basically you should have your own methodology to figure out where your weak areas are and come back to it, and do repetitive revisions of questions and topics. That for me was the most determining factor. So this is just quickly me discussing how I prepared. This may or may not help you, but just to give you an example of how you can go about preparing as an MBBS graduate with absolutely no knowledge, no practical knowledge of any surgical anatomy, any surgical conditions, any surgical management, how I prepared for this exam. So for me, I dedicated about 5 weeks of preparation for MRCS Part A. 5 weeks as in I took I took leave from my work. I sat at home. I did about say 7 to 8 hours preparation per day. I know it's very difficult to commit to yourself like that, but eventually after a few days you'll get there. So 5 weeks preparation, and what I found really helpful was the basics, strengthening the basics of anatomy, physiology, and pathology. Anatomy, what I really found useful was using an anatomy atlas. So I know some of us may be really good with anatomy, but for some of us who don't have that very good picture of the anatomical structures in our mind, especially when it was done back in first year, it's a good investment of time to learn it really well, for not just for this exam, but also for our future career. So I found there are some cheap atlases, or even free atlases online if you want to download, and you can visually see what you're reading about. And that, for me, really helps to reinforce the anatomy basics. And that is really helpful to the exam because they ask anatomy backwards and forwards. Like a lot of the questions cover anatomy, and it really helps to have the basics in hand. So another thing what I did was high yield topics. So after maybe in a particular, if you're reading about a particular topic, after a few questions, you will understand that this is a high yield topic. So those topics, though I read up about it in excess. Like for example, acid base. Sometimes it's very difficult to get the concept of acid base. So once you understand that the concept, you can answer any question that comes with it. So once you have that in your hand, then you don't have to worry about that type of question at all. So it's like acid base, then the restrictive versus obstructive lung disorders. So these are all very high yield questions, which I'm sure you'll understand when you're preparing for the exam. And once you have those in hand, that particular topic is set. Then what I did was I did a topic by topic completion. For example, rather than blindly going into it, just starting the question bank directly, I did one topic after the other. So for the applied basic sciences, a lot of it is fact based. Even for principles of general surgery, just knowing which nerve is medial to, let's say, in the antecubital fossa, the order structures. So these are all basic things that you might find difficult to randomly pull out from your head, but knowing the facts and completing the topics one by one and writing, say, revision notes or having a revision material set aside will actually help. Another thing that I personally found useful is that I focus more on the applied basic sciences paper, the first paper. So I knew that the principles of general surgery may or may not be slightly difficult for me. So I focus more on the ABS paper. For first reason is that it's a 3-hour paper. It's 180 marks, whereas for the second part is 180 questions, whereas the second one is 120 questions. And another thing that I found was that there was a lot of overlap between the principles of general surgery paper and the ABS paper. So whatever I learned from ABS could actually be applied to get my answers in principles of general surgery. So I didn't ignore POSG, but I did do my own preparation for POSG, but the initial preparation was focused on ABS and then went on to principles of general surgery. And like I said, revision is very important for this exam. Dedicated revision time of about 1 to 2 weeks. And I cannot stress this enough. Previous question papers I found very useful. And I did about 3 to 4 timed mocks closer to the exam time, which helped me get into that focused exam mode, which helped me make sure that, okay, fine, I'm taking this much time to finish this exam. I need to focus on being quicker, or I need to change my methodology, something like that. So it gives you a very good assessment of where you stand. So this is how I prepared my strategy, but of course you'll have a completely different strategy. But this is just for a reference on how you can go about it. So now let's look at Part B. The Part B exam is quite different to the other normal exams because it's an OSCE exam. It will have stations. I personally gave the exam here in the UK, and it was a very good experience, actually. Everyone was really nice. The examiners were really understanding. They put you at ease. So that's not something that you would have to worry about. But yeah, so this exam itself is aimed at co-training 2 doctors for those who are nearing the completion or have completed their co-training here in the UK. It is an OSCE of structured clinical examination. It has stations which test your knowledge and skills of communication as well as examination, and it lasts for about 3.5 hours. Roughly 9 minutes per station. Some stations have 6 minutes for us to perform and 3 minutes of viva. So this is a very quick. It's a chart which shows a division of how the stations will go as you prepare for the exam. I'm sure if you're preparing with Mortimer Green, they will give you very good training on how each station should be approached. So a few tips on how to prepare for Part B. I found that it's very important to allot a sufficient amount of time, a sufficient amount of dedicated time to prepare for this exam. Like I said, it's an expensive exam. You want to give it right. You want to get it right the first time around. So there's no point giving the exam unless you're prepared for it. So nothing can really, what do I say? Nothing can make up for good preparation. So give it good enough time. Take break from your whatever work you're doing if you have to, and give it a good, give it adequate time. The next thing is practice, practice, practice. And a lot of the time when we prepare for exams, we tend to read and understand, but that does not necessarily transfer or translate to actually performing it. Part B is a performance exam. You have to perform in front of a group of examiners, and you have to perform under the pressure of time. So if you don't practice actually performing them, it may not be possible for us to do it on the day of the exam. The third thing is group study. I found this extremely beneficial. So group study, as in if you're sitting in a room and if you're preparing and reading particular, say, preparing for a particular station, there's a difference between that and actually enacting it with someone who's acting as an examiner, someone who's acting as a patient. The memory of actually doing it, to actually understanding the problems that you might face while performing it. For example, for me, I used to speak really fast. I still do, I'm sure, but I used to speak really fast, and I was given this feedback by my colleague who was acting as my examiner when we were doing a group study. And this really helped me during my exam, where I was conscious enough to explain to the patient, okay, run them step by step while I was doing the examination. And for me, that I'm sure helped in the examination. And another thing that I was given feedback for was communication to the patient. These are really things that the examiners in the UK MRCS exam will keep an eye out for. Then the third thing is fourth thing is time management. It's the main thing for this exam is that you have to finish the station in the time allotted. If you have 6 minutes, you have to finish in 6 minutes and attend your viva for 3 minutes. You will not be given extra time. So practicing or performing the station itself will make sure that you're prepared to finish that task in that particular time. So that's very important while you're giving the exam. And lastly, like I said, recreating exam situations. So once you've done the basic work of knowing what the stations are, what you're expected to say, then it's really helpful if you have a couple of people recreate exam situations where you have one person acting as the examiner, one person being the patient, and one person being the candidate. So, and you can take turns, take turns doing each, and that will actually help all three of you perform in the exam better. So this is another discussion on how I prepare for the exam. Like I said, that may or may not be applicable to you, but just a point of reference. I dedicated 1 month, myself along with my colleagues. We took 1 month off and prepared for the exam. And some surgical experience that I had. So I was working in a surgical department before giving the exam for a few months. And the experience that I got from working there really helped. Like I used to get the chance to close surgical wounds. So suturing experience really helped. Knot tying experience really helped. I was confident in catheterization because I used to do all pre-op catheterizations. So these are all stations that that actually come in the exam. So if you have some surgical work experience, that really helps. So if you're doing your internship now, this might be done in your internship. You can, during a surgical rotation, you can try and take an active effort to catheterize patients, active effort to suture patients. I'm sure your seniors would appreciate that. Or if you're working in a hospital at the moment, you can try and get a surgical rotation. You can actually look for, seek out surgical chances to do surgical procedures or suturing or anything, just to make sure you have that speed and that technique. Or even you can attend courses like basic surgical skills. They'll teach you and they'll give you materials to practice your skills. And the third thing is, okay, so about this preparation resources. So main thing is to understand the format and what is expected of you from the exam. Most resources, and I know Mortimer Green does because I did my training there. They will give you a format with the stations that are given that are covered in the exam, and they'll give you a description of what is expected of you in that station. For example, if it's a communication station, this is what you should say, or this is what is expected of you. So you will going through that material will give you an idea of how to perform in that station. So go through that really well and understand what and how to say it. And the fourth one, like I said, group study is very important, along with some self-study of when you can. So, for example, Part B is not just skills. There is also a knowledge component. You have stations which cover critical care, anatomy, pathology, etc. So for those stations, some self-study will really help. Like I said, I recreated exam conditions and performed in time stations that really helped. And the main focus on during the preparation time was communication with the patient, timely completion of the station, skills and knowledge. So these are the areas that the examiners will look when they are being assessed for the exam. And finally, identifying any weak areas that you may have. Like, that's why I said it's important to do with other people so that they can point out where your weak areas are and you can work on them and put your best foot forward for the examination. Finally, the UK surgical pathway. So this is, I'm sure some of you might know this, some of you might not know this. That's why I'm covering it. This is a rough guide, like a simplified version of the surgical pathway in the UK for training. So first, you have a 5 years standard undergraduate medical course. After that, you have 2 years of foundation year, which is FY1, FY2. And if you want to do an extra year, you have the option of doing the FY3. There's also a standalone FY2, which is mostly aimed at international medical graduates like ourselves, where we've done 1 year of internship in our native country, and then we can do the second year of internship, which is the FY2, as standalone FY2 here in the UK. So if you have a GMC, then you can apply directly for FY2, standalone FY2 post here in the UK. And then after the foundation year, to apply for core surgical training, you have to apply through ORIAL. ORIAL is a website, is a unified national website for all sorts of training applications. And you have to sit the MSRA, which is a multi-specialty recruitment assessment, which is basically like an entrance test, which lets you into training for several specialties, including psychiatry, general practice, neurosurgery, core surgical training. So you have to sit the MSRA exam before you apply for core surgical training. And then after foundation, if you finish the MSRA, if you get a good score in the MSRA, and then if your portfolio is good enough and you pass the interview, you will get into core surgical training. Core surgical training is 2 years, CT1 or 2, or if it's a specialty training, if it's a run-through training like in neurosurgery, you directly go into ST 1, 2, 3, 4, 5, 6, 7, 8. But yeah, core surgical training is essentially CT 1 and 2. It is 2 years. And at the end of core surgical training, you're expected to have your MRCS. Specialty after core surgical training, again, you will have to apply for specialty training through ORIAL. It's you don't have an exam for it. What you have is portfolio. So during your 2 years of core training, you're expected to get all the necessary qualifications in terms of publications, in terms of surgical experience, in presentations, everything, all of the necessary checklists ticked, so that when you apply for specialty training, based on that portfolio you have developed in the 2 years, you can get a rank and get a number for specialty training. So specialty training is for 6 years. Most surgical specialties have 6 years. Some have shorter, 5 years. And at the end of specialty training, you'll be in ST8, and you would have completed specialty training. And after, at the end of specialty training, you're expected to write your FRCS. And once you have your FRCS and completed specialty training, you can apply for a CCT, which is Certificate of Completion of Training. And once you have your CCT, you are a consultant surgeon in the UK. So this is the standard training pathway for UK, in the UK for surgery. So let's be completely realistic. The surgical training is not easy to get into for everybody. If you're lucky, you will get into it. But the good thing about the UK is that is not getting into training is not the end of the world. You have several other opportunities, several other options to get into a surgical career, even if you don't get into the major or the mainline training. So these are some of the options that you have. Some of these I personally came across them only after coming to the UK. It's not very well known, so I'm using this opportunity to let people know that these are other options that you actually have. The first one is ACF, or the Academic Clinical Fellow. The second one is regional programs or CoTraining Equivalents, which are basically master's programs done by local trusts that give you 2 years of rotations within the trust, and at the end you're signed off your competencies. And the last one is standalone competencies, which is basically you yourself can work as a non-trainee, and one of your consultant or any one of your senior consultants can sign off your competencies, saying that okay, this person has the necessary qualifications to enter specialty training. And that itself that will, if you upload that form, you can actually apply for higher specialty training. So the first one that I discussed as an alternative is the Academic Clinical Fellow. This is not a very easy rotation to get. It's very competitive. It's an NIHR funded program. It's usually 3 years, sometimes 4 years in say GP, but for surgical specialties is 3 years. It's basically dedicated. I mean, it's a clinical rotation with dedicated research time in the ratio 75-25. So 3/4 of the time you have clinical time if you work in a hospital as any other specialty, but 1/4 of the time you have protected research time. These are very competitive posts, up to 30:1 competitive ratios. If you're really interested in research, this is a really good option if you can get through. Applications are through Oriel, and applications happen in October to January. The next alternative to co-training is CoTraining Equivalents. They are 2-year programs usually done locally by certain trusts. The degrees are different. Some are MS degrees, some are MSc degrees. Master of Science degrees, say they're done in trauma and orthopedics, they're done in surgical innovations, they're done in plastic surgery. So there are theme rotations where you have 4 6-monthly rotations for 2 years. So you'll work in that trust, and at the end of 2 years, you'll be given an MSc degree, and that is considered a co-training equivalent. If you have that degree, you can apply to higher specialty training as well. This is not something that I've heard of before coming here. So it's actually, that this is definitely an alternative pathway to post-surgical training. And like I said, the CREST is basically a certificate given, not certificate, it's a form signed by our supervising consultant, which lets the training team know that we are competent enough to apply for higher specialty training. It basically says Certificate of Readiness to enter higher specialty training. Finally, the applications for these posts happen through NHS or track jobs. You can apply online when these posts open up. If none of these work out, you always have the option of doing standalone rotations. You can do 6 monthly non-training jobs, or even if you really like the department, you can stay for 12 months or more. till you get a certificate signed off by a consultant saying that you're ready for higher training application. So the pathway would be do your MRCS, you can get your GMC registration, apply for a non-training job. Once you're happy there, once you have settled in, you can ask one of the consultants to monitor your progress and ask them to sign the CREST form for you. And they will, based on how they assess, based on assessing your performance, they will sign off the CREST form. And once you have the CREST form signed, the next application, in the next application year, you can apply for your ST3. So this is definitely a good option. And this doesn't, even if you don't get an ST3 number, ST3 basically specialty training number from, specialty training number in the usual routine pathway, this itself can be done all the way up to your consultancy. So you can, after 2 years as a CoTraining Equivalent or an SHO job, you can step up as a registrar, and you can do 8 years of standalone rotations. You can do your own rotation in certain trusts, and finally get all the competence necessary to become a consultant in the UK. You can give your FRCS, and after that, you can get your competency signed off by their then consultant and get the CESR route. So Certificate of Entry into Specialty Registrar. So CESR is basically the alternative route to get your consultancy here in the UK. So there are several routes. So yeah, my point is that there are several routes to complete your surgical training here in the UK. My personal observation here where I work is that there is not a lot of difference between training doctors and, locally trained doctors. It's a little bit more stressful for the locally trained CESR doctors because you are responsible for getting your rotations, but it's not impossible to do. So I'm just letting you know of the different alternatives that you have as an MBBS graduate who is aiming for a surgical career in the UK. So the next topic that I would like to talk to you about is how to get into the stream of the NHS, basically how we can make ourselves look very attractive to the NHS employers. So here, for any job, the main thing the things that they look for are MRCS, audits or quality improvement projects, presentations, publications, and teaching experience. Universally, whether it is whatever level that you're applying to, these are the main areas that they focus on: research and presentation, teaching, and our examinations. So having the MRCS out of the way, that is one definite benefit that you have in making yourselves appear attractive to the NHS employers. And the other things that you have to work on, either at home in India itself, or once you come here and get in the first job, what you can focus on is doing your audits, quality improvement projects, doing some research work. It doesn't have to be very major. Even whatever minor research work that you do, you can present it in certain conferences. The bigger, the better. Try and get publications and teaching experience. So teaching experience, what I did was I found a local, I was working in a local hospital, and I did some teaching experience for the nurses, teaching classes for the nurses there. And I got a certificate signed off from the consultant. This is something that you can do in your hospital as well. And that is very much valid here. But for the other things, I found that it's very much of slightly more of an uphill battle doing it in India than doing it here. It's all valid, even if you do it in India, whether you do it here. But it's slightly more easier because everybody's doing it here. So if you want to do an audit, you just have to approach one of your seniors. They probably will have audits in line. You just have to join as part of it. So it's easier for you to do an audit here than in India. But having one in India when you apply for a job here will definitely boost your CV. So when I applied, I had the MRCS, I had an audit, I had one or two presentations and a publication. And for me, it was not very hard to get a job. So that is what really sets you apart when you apply. So I would say if you're preparing for the MRCS, that's great. But at the same time, it might really help to focus on doing an audit, doing a small presentation in any one conference, doing a poster, any poster. It doesn't have to be very hi-fi or large. It doesn't have to be a large presentation at all. Any small thing will really help in putting your CV slightly more at an advantage than someone who does not. But of course, if you have any questions, I'm happy to answer at the end of the presentation. So yeah, this is again another slide talking about how you can get into the training pathway. Everybody here wants to do training pathway. Obviously, that is our major, that's our main goal. If not training in India, you want to do training in the UK. So this is just a slide which talks about how you can do training in the UK. So first of all, CoTraining, which is 2 years, like I said. So as an MBBS graduate, you would aim to get into CoTraining. So to apply for CoTraining, you need foundation competencies, which is signed off by the CREST form. So if you've worked in India, then you might want to think about getting your consultant who you worked under to sign the CREST form. All of this is available on the ORAL website, which is given here. You can download the CREST form from the ORAL website, and if when the applications open, usually open in October to November, you can download the latest CREST form, get your consultant to sign it, and upload it when you apply. So when you apply, you'll get invitations to the MSRA, which is the exam, multi-specialty recruitment assessment exam that I discussed before. If you clear hopefully you'll clear the MSRA, after which you can submit your portfolio. So for core surgical training, they'll ask you about your presentations, your publications, the number of surgical cases you've been part of. I'll show you an example in the next page. But yeah, so based on how much of your surgical experience is, how much of surgical experience you have, you'll have to upload your portfolio. And then based on that, you will be scored. And if you have a high enough score, you'll get an interview. And if you have an interview, it's a really good chance you'll get a number as well. And you'll get offers to different locations in the UK. And you'll be given 2 years of a protected visa. You will be part of a training program in the UK. So that's the most ideal route, directly after an MBBS in India. So that's what everybody aims at. So the MSRA has 2 parts essentially. So if this is something that you're aiming to apply to, you would definitely prepare for the MSRA as well. MSRA has 2 parts, which is the situational judgmental test and the clinical problem-solving paper. Clinical problem-solving paper is basically like any other MCQ with all the 19 subjects, including psychiatry, general medicine, respiratory, everything. But something that we're not familiar with is the situational judgmental test, which is basically a section where you'll be asked questions about how you approach ethics in a medical situation, in a hospital, how you would think about how you would respond to a particular situation in the hospital. You will come across questions like, okay, your colleague did this, how would you respond to it? Or you found your colleague using alcohol while he was at work. So then how would you respond to it? So basically some questions that we are not used to as an Indian medical graduate. So that might need a little bit of preparation. But other than that, MSRA is just like any other MCQ exam. And once you've given the MSRA and get an invite to submit your portfolio, the portfolio, like I said, these are the areas that the portfolio covers. So if you want a really good score in that, you might want to work on audits, publications, operative experience, etc. So once you've applied for the CoTraining, gotten a number in CoTraining, did 2 years of CoTraining with 4 different rotations, then you will apply into specialty training, which, like I said, is a 6-year program. Applications are done through Oriel. It's very similar application process. The only thing is that currently there is no examination before specialty training. Directly you upload your portfolio, and if you have enough score, have a high enough score on your portfolio, you will get an interview, and then you'll be offered a training number. So again, like what you're graded on is essentially the same, whichever level of training you're in. The only thing is the operative experience that varies. So these are examples of the portfolio scoring or self-assessment portfolio scoring that are there for they're on the Oriel website. The left one, the blue one, is for co-surgical training. So it talks about your involvement in surgical cases, conferences, electives, etc. And the one on the right is talking about specialty training posts. So they're all available on the Oriel site if you want to take a look. Finally, I'd like to wrap up this discussion with giving you a small insight into what life here is as a junior doctor, just so you know this is what we can expect once you come to work here. The work hours typically is capped at 40 hours per week on an average. Then again, it's not 40 hours per week every day. If you're on call, you do 12 hours a day. So if you'll probably have 3 on calls a week. So you'll have 30 hours in that week. So then the week after you'll have 36 hours in that week. So you'll have 44 hours in the next week. So on an average, a month you'll have 40 hours a week. It's a 5-day week. Unless you're on call, you don't have to go in on Saturday and Sunday. But the rotation, the rota or your schedule will vary depending on the specialty you're working in, depending on the trust. So if you have, say, an ED rotation, or if you're working in general surgery, your rota will be different from if you were doing any other surgical post. Generally, as a junior doctor, as an SHO or as a CT 1 or 2 equivalent, you will be expected to do on-calls, 12-hour on-calls usually. You'll be expected to cover the wards, some clinics. You'll definitely get some theater time. Then you will have both supervised and independent management of patients. So in ED, in the casualty, you might do some independent management of patients for simple cases. But for more complex cases or in theater, you'll very much be supervised. And obviously, what I found most glaring was there is a very obvious difference between our system in India and our system, and the system here in the UK. Working in the NHS definitely has a learning curve. I've been working here for close to 9 months, and I've only just started to become more comfortable and more confident in the system itself. So give yourself that time and prepare yourself for that huge difference. But it's not something impossible to get acclimatized to. Definitely is doable. And the most important question that we all would have is how much we are paid. So it can be anything from 35,000 to 43,000 a year. Plus, if you're doing like an on-call, then you'll have on-call allowances, which is about 40 to 50% extra of this. So as a junior doctor, you'll get roughly £2,500 to £3,500 per month after taxes. Again, it's very variable depending on the rota that you have, if you're either doing on-calls or if where you're working. So London has something called a London wage, which is £2,000 per extra, £2,000 per year extra. So it's very variable, but roughly it's around 2,500 to 3,500 per month after taxes as an SHO or a junior doctor. So this last slide, I just wanted to say these are very frequently asked questions, or questions that I get from my juniors who are thinking about this particular pathway. So I've already covered most of these topics in somewhere during the presentation. So I just want to run through them, and I hope I've answered them. So first question is, which college do I apply with? So you have 4 colleges. Doesn't really matter which college you apply to in the long run, but each college has its own small differences, like say Edinburgh. I've already covered this, so if you have any doubts, you can ask a question on the chat. Like I said, how long does it take to complete? You can definitely complete within a year, like we discussed. And does it need surgical experience? No, it does not, but surgical experience definitely helps. Can I write it during internship? So for this Plab, you can write it during internship, but for MRCS, you need your complete medical degree. Can I enter PG directly with MRCS? Is a question that I've been asked, but no, MRCS is not an entrance which gives you a definite, which guarantees a seat to any training or any PG. It is just a diploma which tells you that you have certain competencies, but it will not guarantee any PG or any training seat. Is it easier to get into surgical training in the UK than in India? That's a very complicated question to ask, because in India you have an entrance. If you sit properly and study for that entrance, you can get it. But in the UK, you have to keep applying, build up your portfolio, and if you're lucky and if you've done what is expected of you, it is possible. So it's not easy to answer that question. Both surgical training is difficult in the UK as well as in India. Both of them have their own pros and cons. But yeah. So the last question is, what is it like as a junior surgical doctor in the UK, which I have explained in the last slide. So with that, that's basically what I wanted to say. Thank you so much for listening. And I'm going to use this time to answer any questions that you might have. So, okay, so starting from the beginning, what does Plab 1 preparation help us in preparing for MRCS Part A? Is it better if a person attempts Part A after Plab exam rather than attempting the MRCS Part A as their first exam in the UK pathway? I personally felt that it was the other way around. I focused on the MRCS rather than Plab, and I prepared for the MRCS Part A. And after giving the MRCS, I gave Plab. So I didn't prepare anything for surgery. I just focused on the other, say, psychiatry, medicine, and all that. And that, for me, that helped. But the converse, whereas Plab helping for MRCS, I'm not 100% sure, because the MRCS is much more focused than Plab, and it covers, or it focuses on surgical aspects mostly. It will help definitely, because it's an exam at the end of the day, but I'd not, in terms of the exam itself, preparing for Plab, that wouldn't guarantee a higher pass rate for MRCS, especially being much more difficult. I mean, the pass rates being much lower than Plab. No, I don't think so. How many attempts are allowed for MRCS Part A and Part B? Let me just check. It's, I believe, 7 and 4 for Part A and Part B. Sorry, let me just check maximum attempts. I believe it's 7 and 4. Sorry, Part A is 6, actually, not 7. And Part B is 4, I believe. Yeah, 6 and 4. Okay, so MS in India versus MS in the UK. So, like I said, here training is not an MS. It is a training pathway which is 8 years long. This also is very different, because the training pathway in India is very different from the training pathway in UK. So training in India is 3 years of general surgery followed by 3 years of MCH, which is in 6 years you'll have finished your training in India. Whereas in the UK, it's 2 years of core surgical training followed by 6 years of specialty training, which is 8 years. Even though this is longer, the working hours and the work-life balance that I've seen comes from that I've seen here in the UK is slightly more, not slightly, it's definitely more than that in India, especially if you are a surgical resident. So even though it's slightly longer program, you don't really feel like, you're under rigorous scrutiny. But in India, um, the MS and MCH are separate degrees. It's not that way in the UK. Then you can practice in the UK, in India, with an MS. You can't really practice. You can work as an SHO in UK as with a co-training, but you won't really be able to be a consultant in the UK without progressing and writing the FRCS eventually. Then in terms of the surgical exposure, I would say essentially it's the same, because if you're in training, you have to get competency signed off. You have to, it is your trainers or your seniors consultants' responsibility to make sure that you have all the necessary surgeries done, that you're able to perform them in without supervision. So that way your surgical progress is guaranteed. Whereas MS in India is quite variable in terms of where you do it, who you're working under, etc. So there are a lot of differences between MS in India and surgical training in the UK. I wouldn't say MS in the UK because that's not there. Patient exposure in the UK. So this is something I've heard when I was considering the UK as well, that patient exposure is not there. I disagree, because definitely we don't have the high loads of patient exposure in the UK, even if you're working in the NHS, as compared to in India. Because in India, in an OPD, you would see close to 100 to 200 patients. Here in an OPD, you would see 20, 30 patients. But essentially, I don't think there's a huge difference whether you see 200 or 20 if you do the 20 properly. It's essentially because you're not rushed through the whole process. If you have dedicated appointments, you have 20 minutes or 15 to 20 minutes appointment per patient in the UK. You're not expected to see 5 patients in 20 minutes. You are expected to see only that one patient in 20 minutes. I don't think that's a huge negative. But in ED or in the casualty, if you're doing on calls, you will see a lot of patients. You will see cases. You will, depending on where you're working and the specialty you're working. If you're working in a major center, you will see patients. The number may not be as much as in India, but I don't think that makes a huge difference. Are job prospects in the UK better if we go through the MRCS pathway after MBBS rather than Plab pathway? Definitely yes. If you have Plab, if you're being compared to a person who's given the Plab exam and you have an MRCS yourself, for the same job, you would definitely be preferred over the somebody without an MRCS. Degree value of MRCS in India. I'm not sure if you're on the group, but Dr. Vinayachandran had posted a bit of a write-up where he talks about the MRCS as a degree in India. You cannot practice as as a senior resident or anything with just an MRCS in India. For us, you have to have our MS or MCH in India. But that changes if you have an FRCS. So with just an MRCS, you cannot be equivalent to a postgraduate in India if you don't have the MS. But with an FRCS, if you complete your FRCS in the UK and then go back to India, it will be equivalent to an Indian consultant. Can one get directly into special surgical branch without a general surgery degree? Yes, you can. With an MRCS, you are eligible to apply for an ST3, specialty training. But as long as you have the MRCS, yes, you can. But you also have to have the other competencies or other portfolio up to the mark. So like I said, specialty training is not just about having one exam. It's about having the exam and your surgical experience and presentations and audits. And so it's basically you're scored based on your portfolio, and MRCS is one part of the portfolio. Without MRCS, you can't progress to specialty training, but you also need the other things. So having the MRCS will not guarantee that you will get a training number, but it is possible. Any specifics for preparation resources? There are lots of resources out there for Part A and Part B. For Part A, what I used was, for Part A, like I said, for anatomy, Atlas, Mortimer Green is a really good resource. For anatomy, I really use the Atlas to read about, to get the fundamentals correct. And I use the Raftery textbook, which gives you a bit of a concise anatomy, pathology, physiology for the exam. And any question bank, including the Mortimer Green one, will give you the fundamentals. So that's for Part A. And for Part B, like I said, you have two or three aspects for it. One is the knowledge station, where you need to read up about the topics covered and what you're expected to answer in each viva. It's a viva like any exam that you've had in your undergraduate or your MBBS course. So for those, you have one set of preparation. You'll have materials, and the next one is a skill station where you have examination and communication skills and history taking. For that, you need to have materials, which again will be provided by, say, Mortimer Green or any other course that you subscribe to. And on the other hand, you have to practice with them. You have to do a group study or perform and practice to be really comfortable in giving that exam. So that's what I would suggest for preparation. So these three things. If someone has passed MRCS A but is not able to pass MRCS B, then how much time will MRCS A be valid? Again, I believe it's 5 or 7 years. I believe it's 7 years. Let me just check. 7 years, yes. It is. So if you pass MRCS A and you have 7 years before that MRCS A validity runs out, or you have 4 attempts at MRCS B. A couple of queries. Yes, of course. Is ECFMG needed to register for MRCS Step 1? No, ECFMG is not required for MRCS Step 1. For MRCS, you just need to apply. Through the Royal Colleges, you can apply for Part A and Part B. And ECFMG is required before you apply for your GMC registration. So once you have MRCS Part A and Part B, and you're ready to apply for your GMC registration, they will be expecting you to have your primary medical qualification validated by the ECFMG and uploaded onto the ECFMG. So what I would do is, or what I did is, during just before my Part B, I got my MBBS degree updated and validated by the ECFMG, so that by the time the results came and I was ready to apply for GMC, I had the necessary documents already, so that I didn't have to lose a lot of time waiting for ECFMG verification and all the paperwork. But MRCS itself does not need ECFMG. What kind of letter do I need if I haven't received my MBBS degree yet? Okay, so without your degree, if you can apply for your MRCS if you've completed your MBBS and have done your internship, but you're waiting for your degree certificate, then in that case, I submitted my provisional certificate, and my internship certificate, and I emailed them saying I'm waiting for my MBBS degree because of so and so reason. I haven't gotten it yet, but I've completed it and I've got these certificates to prove it. And as soon as I get my MBBS degree, I will upload it. And that wasn't a problem for me. So I would say provisional MBBS certificate, degree certificate, and your internship completion certificate. But to be honest, I wouldn't worry too much about this because you have their email ID and they are quite good in responding. So if you have any queries, you can directly email them and they will get back to you. Is there any minimum surgical experience mandatory to be eligible before we sit Part B? No. On paper, there is no surgical experience required. As long as you have your primary medical qualification, which is your MBBS, you're qualified to write Part A and Part B.
Thank you very much, ma'am.
No problem. I completed my degree in Kyrgyzstan and 5-year course. I did not clear my FMG, interested in UK, Plab or MRCS. So are you interested in following a surgical path? Definitely, or is it a medical or so again the question begs, like, if you're definitely thinking about a surgical branch, then if you're able to crack the exam, I would say MRCS is definitely a good option because it helps you not just get an not just get a license to practice in the UK. It also gives you an advantage in time, in advantage over your colleagues or your peers applying for the same job, those who don't have an MRCS, and it gets a surgery exam out of the way. Whereas Plab is just a licensate exam. But if you are not confident about a surgical branch, if you're not confident about your basic surgical skills, then Plab is a bit more of a safer exam because it gives you time to decide what specialty you want to do after your MBBS, and it also is more broad based. So I would suggest thinking about what specialty you're interested in first. Kindly discuss about getting into the training pathway in the UK for post-MS. Okay, for post-MS, right. So for post-MS, a lot of my colleagues here, what they are doing is, okay, core surgical training is way out of, really don't need it. In that case, you would be thinking about getting into specialty training. Specialty training is basically, like I said, a 6-year investment where you apply through Oriel, upload your portfolio, and based on your portfolio score, you get a training number. If your portfolio score is high enough, you get a training number, and you get into training. So there are separate applications for every surgical, specialty, like for plastic surgery, general surgery. So general surgery will cover upper GI, colorectal, etc. So plastic surgery, general surgery, orthopedics, then neurosurgery is a run through. So you have to apply directly from ST1 again. So every surgery, so for higher specialty training, you would have, as an MS graduate from India, you would have to write the MRCS, get GMC registration, and I would suggest start as a non-training registrar here rather than an SHO. And once you work as a registrar, you can simultaneously build up the portfolio requirements for the specialty training pathway and apply to your specialty training of your choice, and get in through Oriel. I hope I answered your question. If not, please ask again because I wasn't entirely sure about what the question is. But yeah, to answer it short, is ST3 applications would be the right pathway for you. My experience of facing part B, how were the questions like? How did you answer or tackle it? Okay, so like I said, I gave the MRCS part B here in the UK, and the examiners itself was really nice because I was really concerned about how daunting the day would be, but it was actually a very pleasant experience, very well organized. And so I believe there was 17 stations. Let me just go back to go back to the screen where that is done. I can answer this question there. Sorry, just 1 second. Yeah. So can you see the slide? So in this, like I said, so there are anatomy stations where you're basically given a viva of, say, the skeletal bones, or you're given pictures of a certain anatomical location, and you're asked to identify what is what, say a nerve, or say an example is the skull base foramina. You'll have the different foramen and what comes out through that. Then there's pathology stations where you're asked about any particular condition or particular organ and its pathologies, etc. So these are all knowledge stations. And then you have the critical care stations. So you have knowledge stations and skill stations. So knowledge stations is mostly Viva, and skill stations are again divided into communication stations and procedure stations. Communication station involves you talking to a patient and either eliciting information or giving information. So either history taking or explaining to them about a procedure and taking their consent. These are all common examples of a communication station. Or you have colleague communication as well as patient communication. So patient communication may be consenting them for a procedure or calming them down when they're angry or something like that. And colleague communication will be talking to a senior or telling them about a sick patient, something like that. So that the communication station will cover that. And procedural skills will be, say, examination of a lump, examination of the abdomen, examination of the leg, varicose veins, or orthopedic examination. Then procedures will be catheterization, gloving, incision and drainage, suturing. So when you're preparing for the exam and you've signed up for any course, they will cover the whole thing, including they'll give you a proper word by word, station by station explanation of each of them. And as long as you follow that, you would be completely safe. So essentially, there'll be these, I think 17 stations, and each station will have around 9 minutes. And some of them will have 6 minutes for you to perform and 3 minutes for Viva, etc. So I wouldn't worry too much if you're taking a course, and they will help you through it. Okay, so what kind of job should we look for before taking MRCS Part B? So if you're sure about surgery, I would suggest looking for a job which has a surgical rotation or has some surgical component. I personally did, I joined general surgery as a non-training or a non-academic JR, where I had on-calls, I had surgical time, I was involved in the theater. So I was comfortable with surgical history taking, basic surgical procedures like the ones covered in Part B. And I was used to the whole managing certain surgical emergencies, managing certain surgical communications, etc. So just basic, it's about familiarity. It's not necessary, but if you're more familiar with it, you know what you're talking, you know what you're thinking about. For example, if you've not routinely managed a patient, then they'll ask, then you wouldn't know, say, after post-surgery, a patient is coming with decreased urine output. What would you do? You would try fluids. So this is not something that, as an MBBS graduate, not everybody would know. So, but if you've managed a patient in a surgical ward, you would know that. So this is something that would give you less anxiety if you're more familiar with that. That's all. So I would suggest, if you have surgical jobs, even if you have a surgical job, that would be better. Another option for an MBBS graduate, if you don't have a surgical job, or that can help you do for not just Part B, but also for applying for jobs and for other future career, is doing certain courses like ATLS, CCRISP. Like CCRISP is basically care of the critically ill surgical patient, DSS. All of these courses are really good in preparing you for such exams as well as for a surgical career. So if you have time while applying for or while preparing for the exam, you can also do these courses and it will help. How many years is the higher surgical training for plastic surgery? So for plastic surgery, it's 6 years, ST3 to 8 after core surgical training. Can one apply for MCH in India after MRCS in UK? I don't see why not, but I'm not sure. So that then you wouldn't be thinking about an UK surgical pathway, right? If you're thinking about continuing your pathway in India, then the MRC is definitely a good addition in terms of having an additional feather in your cap. But in the Indian pathway, I'm not very sure if the MRCS alone is very useful. in the case of run-through options, do we still need to do CT 1 and 2? Where does MRCS play a role there? So in the case of run-through, say, for example, neurosurgery or some of the other run-through, I think pediatric surgery also has a run-through option now. No, you don't need to do CT 1 and 2. When you're applying for neurosurgery or pediatric surgery, during your application itself, you will have to specify that you're applying for neurosurgery or pediatric surgery or any of the other run-through pathways, in which case you will directly go into ST1, 2, and it will be a very neurosurgery focused or pediatric surgery focused surgical training. You wouldn't do the other rotations like, say, plastics or CTVS or anything. You do not need to do a CT1 or 2. The training itself will start from ST1 specialty training, as in that run through itself. You do not need to do CT1 or 2. So if you're sure, basically to answer your question, if you're sure about a neurosurgical or a surgical career which needs a run through, then you can only apply for that, and you need not apply for co-training. Sorry, that is qualified for. Oh, okay, fine. So can one apply for MCH in India after MRCS? To Rosen Liu, I'm not sure I understand the question. If it's possible, can you ask again in the comment section? Thanks. Standalone FY2 is mandatory for everyone. No, it's not. So basically, like I said, when you apply, the training pathway in the UK is actually quite fluid. You can actually figure out yourself. It's not like in India where it's cut off. Like you do your undergraduate, then you sit the NEET exam, then you do your PG, then you sit the MCH exam, and then you do your MCH. It's not as structured as that. Here in the UK, you can, based on your experience, you can choose to figure out where you actually stand or where you can apply. So if you have, what I did was I did my internship in India, and I did 1 year extra in general surgery in India itself while I was writing and preparing for the MRC, gave the MRCS exam, then applied for GMC and came here, and now I'm doing a CT1 equivalent here. So you don't have to do FY2. So instead, if you're doing your MRCS or Plab earlier on, directly after doing the exam, if you have no further experience, you can apply for a standalone FY2 here. But if not, you can also do, based on your level, you can and your CV, you can apply for CT 1 or 2 or non-training jobs at the CoTraining level. But like I said, if your CV is not that advanced, if you don't have your MRCS, or if you don't have your say audits or your audits or your conferences or your the other stuff, quality improvement projects, your presentations, everything, then it might be difficult to get a higher level job for you. Instead, a standalone FY2 might be easier. So it's based on how your CV is that you apply, that you figure out which job you apply for, but it's not mandatory. After MRCS, Indian plastic surgeon can apply for ST8, 7 or 8 and give FRCS. I don't think so. I don't think you can apply for ST specialty training 7 or 8. If you have as an Indian plastic surgeon, if you have an MCH, then I probably wouldn't be possible to get a training number and get like an FRCS through a training pathway. Then you wouldn't get a CCT. What you would get is if you come to the UK and you can give the FRCS. You can work for a few years here as a non-training registrar, a high senior registrar. You can maybe complete a couple of fellowships and then give FRCS. At the same time, your consultant here in the UK can sign off your competencies, and then you would get what is called a CESR, which is Certificate of Eligibility to enter into Specialist Register. So that is what is a CESR, which is equivalent to a consultant here for all purposes. You'd be a CESR consultant here in the UK. So you can give the FRCS, you can become a consultant in the UK after plastic surgery in India, but probably not through the training pathway, because I don't think you can enter the training pathway at ST 7 or 8. So, like I said, the pathway, if you've completed MCH plastic surgery, then you can come here. You can either write MRCS or MRCS or Plab. I would suggest MRCS. Get the GMC registration. Come here, work as a senior specialist registrar. Get your competencies signed off. Give FRCS, and apply for CESR, and then become a consultant here. That would be the rough pathway. Kindly direct on how to get a template of the certificate to be signed off by my consultant to prove such a teaching experience. Okay, so teaching experience. What I did was on Oriel for CoTraining, on the Oriel website, which is there in my presentation, you can just go to, I believe it's the resources page, and you'll find the CREST form, CREST, Certificate of Readiness to Enter Specialty Training. Enter Specialty Training, CREST form. And in that CREST form, there will be a section which says like teaching experience, and under teaching experience you will see a particular paragraph which says you yourself has designed, delivered, whatever. There'll be a paragraph which says what to write. So what I would do is I would copy paste the exact wordings of that into a letter, enter, change it so that your name is done. So Vishnu Kuruvital has designed, delivered, and whatever, 4-session teaching session with along with so and so hospital, and get that signed off by your consultant, and that counts as evidence for teaching experience. So I would suggest just using that and using the same wordings as your CREST form. I hope that answers your question. Are on-calls necessary during UK training? So if you are doing your UK training, UK surgical training, yes, you will have on-calls. So like I said, UK core surgical training has 4 rotations. You can either choose to have it themed or non-themed. Themed is if you're sure about what higher specialty you want, you will have more rotations of that rather than the other specialties. So say for example, random rotation would be general surgery, plastic surgery, ENT, ortho. So things like that in the core surgical training. So random 4 core surgical rotations, and most of them will have on-calls. If it's as long as it's an acute specialty, they will have on-calls. Thank you. What are the chances of for an IMG to get into neurosurgery after MRCS rather than Plab? Well, on paper, what they're saying is international medical graduates have the same chance of getting into training as any British trained UK trained doctor, which to a certain extent I think it's correct, because for neurosurgical training you have to write the MRSA exam, which is quite it's an objective exam. It's what is the word? Sorry, yeah, it's an objective exam. So there's no difference between an IMG and a British UK trained doctor. And after that, your portfolio. Again, your portfolio is pretty much an objective thing. As long as you've got all this necessary sign-offs, you've got all the necessary criteria achieved, like you've done your presentations, your audits, etc., then there is not much of a difference between an IMG and a British trained doctor. And if you've got all that and if you've secured an interview, then the interview itself, I wouldn't think they would prefer an IMG or a British doctor over either of the other. So you do have the same chances are essentially the same. It's just about knowing what you're preparing for and knowing how to maximize your points. So I think it's about familiarity essentially. So the difference is a British doctor would know what is required of him and would have started preparing for it from his late medical MBBS days or early foundation days, so that he's more prepared for it rather than us who's coming in from a different country. So if you have that preparation, then it's the same chances, I think. I'm a 33-year-old male with an MBBS degree. Am I too old for surgical training? No, you're not too old for surgical training. But there are certain criteria. There is no age cutoff for surgical training here in the UK, but there is a cutoff which I think after 18 months, if you've been working in a surgical department for 18 months, you cannot apply for core surgical training. You can apply for higher surgical training. So there is no age cutoff, but there is a difference in which level you apply to based on your surgical experience. So if you have more than 18 months in surgery, then you would apply for higher specialty training. If you've got too much surgical experience for that also, to start from an ST3, then it might be difficult to enter training for you. What can happen is you can work as a non-training registrar, get all the competencies required, and get your CESR, get the MRCS and FRCS signed off, and get a CESR consultancy. It's entirely based on your surgical experience, not the age. Post MCS, is it better to join a non-training course? Is it necessary for CREST form for non-training pathway? No, for non-training, you don't have to have any form signed. It's essentially an interview-based, like it's a locally employed post. It's essentially based on an application and an interview. Doesn't require any forms signed. And for post MCH, I definitely think a CESR would be better than starting all over again from ST3. So it would be shorter for you, and it would also, if you're planning to continue working in the UK and to settle in the UK, post MC, a CESR consultant and a CCT consultant essentially are the same. So a few fellowships and a bit of NHS experience, and picking up where you're lacking for an NHS perspective will easily make up for that, I think. What is an ideal gap between Part A and Part B? Something that won't require much explanation. An ideal gap. Most people want to finish the Part A and Part B at the same, like as soon as possible, so that they can apply for their GMC registration without much delay. So, anything more than 28 days will have to be explained. You wouldn't have to give like letters or anything, but 28 days, I believe, will have to be explained when you're applying for anything on ORIAL. So when you're applying for a job or for a training process or anything, there is a section where they ask you for your previous job history or your experience, and you have to give from date to date for everything. So if there's a significant gap of anything more than 28 days, they'll ask for a reason. But if it's more than 6 months, you will have to provide certificates, or say provide, if you have to ask. They'll expect you to explain what you were doing in that particular time. So I would suggest an ideal gap is within a year. So if you're doing a January exam, then I would suggest aiming for the September-October diet for Part B. But yeah, MRCS itself will not require you to exam. The exam itself is, you can give it whenever within the 7 years. But from a GMC or a job perspective, anything more than 28 days, you'll have to explain. After completing MCH plastics in MRCS, how difficult is it to get into a training pathway in plastic? But if you already have an MCH in plastic, would it really benefit you to get into training in the UK? It's not difficult, but there are a lot of things for and against you. One thing that is against you is a number of years after MBBS. So ideally, they try to, you have the maximum score if you have less than 5 years after MBBS. You're scored maximally. It's not that you're scrutinized much for not being in those 5 years. So if say 5 to 7 years will have a slightly lower score, more than 7 years will have a slightly lower score, etc. But it's not impossible to get into training pathway in plastic after MCH. As long as, so if you can go onto the ORIAL site and look for search plastic surgery, ST3 plastic surgery, it will give you, the application will come up, and there the self-assessment criteria will be there. If you can take a look at that, they'll ask you about the number of procedures. For example, for plastics, they'll ask for tendon repairs, nerve repairs, skin grafts, the burn management, then hand trauma like ORIFs, MUAs, etc. These are all surgical experience that is required for an ST3 application in plastics. So based on all that, how much of them you can actually show as a log, and how much of them a consultant can vouch for you and get it signed off. In addition to that, you have the audits, the presentations, teaching experience, etc. And based on all that, if you have all that already, then it's not very difficult. It's just about getting into paper and applying it But if you don't have that, the question is whether being this senior, having an MCH in plastic, do you really need to enter into a training pathway, or whether you can apply for fellowships. You have certain standalone jobs for, say, microsurgery, for breast surgery, breast reconstruction. You have you have fellowship, 2-year fellowship jobs, which can be done, and after a few rotations in 2 years for that, I mean, after completing a couple of jobs like that, you can write your FRCS and get a CESR, which might be easier for you, might be less time consuming for you rather than starting from ST3. I hope I answered the question. I am Ukraine graduated FMG. I cleared my FMG exam currently and doing internship. Can I give MRCS? The certification got delayed a few months. Will I have any trouble in getting an exam and a job? I don't think so. So if you have if you have your MBBS, you say there is a delay in getting a certificate, right? In that case, if you have any other certificate, like say a provisional degree certificate, or like I said, any professional certificate to show that you have your MBBS degree, then you can upload that, or you can send that. So essentially when you apply, they will send you an email asking you for your primary medical qualification. So you can give whatever you have and say, this is my situation. I have so-and-so, but because of the war, which everyone knows, my certificate is getting delayed. And I'm sure they will make arrangements for you. And if not, they will tell you what else you can do instead. So please feel free to communicate with them. They're actually quite helpful. How to smartly apply for surgical jobs? Any particular tips if you could share? So I assume you're talking about a non-training job, in which case, like I said, the smartest tip, if you have an MRCS, great. That would actually help a lot. And just to understand, I think you're talking about say, SHO job, like a CoTraining Equivalent jobs, like CT1 to equivalent jobs, non-training in the non-training pathway. Then in which case, MRCS really helps. A couple of maybe a little bit of surgical experience really helps. So if you what really helped for me is, back at home I had 1 month of plastic surgery experience, which I gave, and I got a plastic surgery job, which really helped a lot. So a little bit of surgical experience goes a long way. MRCS goes a long way. Then having 1 or 2 audits, like one audit, like any one small audit about a surgical thing will really help. So it's not about, so all of these applications are through, track jobs. For non-training jobs, that is, it's a track job application, and they'll have these predetermined questionnaires, which you just have to, like the headings, you just have to answer the heading. So there'll be a heading for teaching experience, there'll be a heading for audits, there'll be a heading for presentations, MRCS, previous experience, etc. So if you have something positive to write about for each of these headings, rather than no experience, then your chances of getting a job and it really increases. So I would suggest, if you have a year when you're preparing for MRCS and you're working in between, one tiny audit, say, even if it's just like, okay, how VT prophylaxis for surgical patients, just very small sample size, 20 patients, that's good enough. Just something to show on paper that you've done an audit helps. MRCS helps. So yeah, if you have any other further, you can please, any further questions, please ask. I'm not sure if I answered them properly. Can you share a timeline about your work experience before entering UK? Okay, so like I said, I finished my undergraduate for my MBBS internship in 2021. I did a year of 9 months of general surgery and 1.5 months of plastic surgery in the same hospital, during which at the same time I prepared for MRCS and Plab. Like I had the same doubt that all of you had, which is which one to give. Is it plastics or which is a Plab or MRCS? And I got through my part ones of both. So I decided to follow the MRCS route, because why write an extra exam? So yeah, then I was lucky enough to find 2 or 3 other people who were giving the MRCS exam with me. I practiced with them, and both of the exams, for MRCS Part A and Part B, I resigned from my job for 1 month and rejoined back. So yeah, so at the end of a year and a half, I was done with my MRCS. Then I applied for GMC. I had all the other paperwork done just after MRCS Part B or during that time, so that by the time the results came, I could apply for the GMC registration. And in about a month or two, I had ID verification, and I had already started applying for jobs. And by the time I had the ID verification, I had an interview and got that job. So it's mostly about planning. So if you have some sort of an idea on what you want to do, and if you get things done, back, in our system, there's a lot of delay. You have your good standing certificate is required for GMC. Your ECFMG is required for GMC. These things take time, up to 1.5 months for them to come through. So if you start earlier on, you'll have all of this by the time you apply for GMC. So it saves time. And one important thing is, here the most common job applications come either during February and during April, May. So if you're ready before in that particular intake, you get a job. If not, you'll have to wait a bit, because the other jobs that randomly come in between may or may not take you. So the largest intake is in Jan-Feb and April, May. So try and get it done as soon as possible so that your GMC is ready before the next intake. That was my timeline. I hope I was clear. As mentioned before, the oral grading criteria needs a number of surgical cases attended, assisted, or independent. But working as a junior doctor after MRCS, would they be able to attend some cases or to fulfill the criteria before applying for ST3 level? Yes. For ST3, yes, you're right. There are certain cases which scores highest if you've done it independently, or if you've assisted, or it's called a work-based assessment, where you have scoring based on how independently you've done a particular procedure. And yes, being a junior doctor, you do have the opportunity to do them either trainer scrubbed or trainer unscrubbed, or even individually might be slightly hard for larger cases. Like, for example, for small cases, you would be able to do them individually. Small, say, debridements or nail bed repairs, everything, you'll be able to do it. But for larger cases, you will definitely have either supervisor scrubbed or supervisor unscrubbed. You will get the chances. I myself am doing them right now and working on my ST3 application. So after an MRCS, it's just about showing your commitment at workplace and asking your seniors to help you with it. And actually, the seniors are quite helpful. I've personally found. And if you show an interest and tell them that, this is what I'm working on, I have so-and-so required, so-and-so procedures required, maybe you will have to assist them in the first 2 or 3, and the third one or fourth one, they'll give you, they'll let you do it. So I think I was able to answer the question. Yeah, you will be able to get your numbers. It's about giving yourself a good enough time to get the numbers for ST3. If one is not qualified the first time MRCSA, yes. So every time you have to, the question is essentially, if you don't pass the MRCS Part A now, the next attempt, you have to pay the fees again. Yes, you have to. Every attempt requires you to pay the fees. And can you practice in India after MRCS and FRCS? So yeah, for an MRCS, with an MRCS, you may or may not be able to pass. I mean, I don't think you'll be able to practice as an MRCS just because you have an MRCS, but if you have an FRCS, yes, you can practice as a consultant. Regarding operative experience for non-training jobs, please elaborate on how. I'm not sure if you mean operative experience when you apply for non-training jobs, or do we get operative experience, operative time for non-training jobs? Well, I'll answer both. For non-training jobs, operative experience, there is definitely when you a column for operative experience when you apply for non-training jobs, but it's not as important as for a training pathway. If you have operating experience, it is important if you're a registrar. If you're applying for a registrar post, operating experience is important. You are expected to do certain procedures on your own. If it's not assessed through your application, it will definitely be assessed in your interview. Management of surgical conditions is definitely important. But as an SHO, not so much. But if you're working in a non-training job, and if the question is whether you will get operative chance, yes, you will. You will definitely get dedicated theatre time, but the extent of how independently you do them entirely depends on your interest and your senior colleague. Because unlike in a training pathway, they're not obligated to sign anything off for you. But if you show interest and actually show the consultant or the senior that you want to learn, and I've personally found that there is a lot of operative experience. My seniors have actually helped me take an interest to teach me and give me operative experience. So I think that is a bit in a non-training job, it's a bit hazy, that definition. It's very much like in India, if you have interests, you definitely will get chances. I'm sorry that it's not a very definitive answer. Can you just give a brief about MSRA exam? Sure. Like I said, the MSRA exam is needed when you're applying for co-surgical training. It's essentially like an entrance exam. It is done through Pearson VUE, just like the MRCS exam. So when you apply for co-surgical training through ORAL, if you've got the necessary foundation competencies, which is done through the CREST form, you will it's done through the CREST form. You will get a link to apply for the MSRA exam, and once you have the link, you can just book a seat and give the exam. And on the exam itself is a two-part exam. There is one is situational, clinical problem solving, which is like NEAT, which is basically like which covers all the 19 subjects from dermatology, psychiatry, medicine, res, pharmacology, everything. And the other part is SJT, situational judgmental test. So I'll talk to you about the SJT in a second, but essentially both of them have equal weightage in terms of giving you a score. So the point is, just facts itself is not the most important thing. The SJT is an equally important part of the exam. SJT is basically, if you can just Google situational judgmental test, MSRA, you'll get a lot of examples of what the questions are like. Essentially, the questions assess your ability to ability in how you react to a situation in the NHS or in a UK hospital. For example, it deals with how you communicate with the patient. It deals with how you communicate or how you react to your colleagues. It has nothing to do with medical knowledge. It only assesses your soft skills, essentially. Like for an example question is, so if a patient gives you a chocolate, or if a patient gives you 100 pounds as a gift, how would you respond? So again, in preparation for MSRA, there are several the question banks which give you answers, prepared answers, and tell you how to answer each question. So I wouldn't worry too much about that. So you just have to sign up for any one course material, and they will do the questions, and you will be able to crack the MSRA exam. Post MCH, is it better to join a non-training course? Is it necessary for CREST form for non-training pathway? No, you don't need CREST form for a non-training pathway. What you need is, if you want to become a consultant, you will need a consultant to sign off your CESR, competencies. I'm not exactly sure what they are, but you will need your consultant to sign off CESR, not a CREST form. CREST form is for co-training. CREHST is for specialty training, and CESR form is for consultancy. And for MCH, I do think it's better to do a non-training route, because it's basically a matter of spending an extra 6 years doing something you're already aware of. So instead, you can build on your already available basic knowledge, doing a few fellowships, and write the FRCS and directly get a CESR consultancy. I think that would be easier easier as an MCH, plastic surgeon or any other surgeon. Regarding operative experience for non-training jobs, okay, like I said, depending on the seniority, they do give you, for non-training jobs, a lot of it depends on your relationship with your consultant and how much faith they have on you. But you will definitely have surgical opportunities, because as a non-training registrar, you are expected to run your own operating theatre, or at least do your own surgeries in an emergency setting, and on an elective setting, at least with the supervision of your consultant. So I do believe there is significant operative experience in in theaters, but that also depends on the specialty you're under and the consultants you're under. It is not as uniform as in a training job, but I do believe that if you have the necessary know-how, if you have the necessary skills, then I'm sure you will get emergency operating chances. But for electives, it's still a little bit protected. But yeah, again, it depends on the unit, the consultants, and also the hospital. If it's a DGH, I think maybe it's a little more protected, whereas if it's a major trauma center, then the caseload is high and you will obviously get more surgical. So if you're smart, I think you have to be smart in applying to a center where you will get the necessary experience. And it's also very fluid, because if you go to a center and if you don't think you're getting enough operative experience, you can always change. It's not like in a training center you have to stick to that particular place for so and so time. You have fluidity in terms of where you are doing your training. So if you like a particular area, you can stay there for a while. So in plastics, if I think you're talking about plastic surgery. In that case, I'm presently working in a center which is really good for plastics, and there is a lot of all the registrars are really happy, the fellows are really happy, so it would be good. Which is I'm working at the Royal London, and if you're interested in plastics, you can always apply for the Royal London Hospital. Is the MSRA necessary to apply for CST if one has completed MRCS? Yes. So for core surgical training, the MSRA is necessary irrespective of your MRCS status. Is it must to have MRCS fellowships in the UK? Are observerships available? For fellowships, I'm not sure which level you're talking about. If fellowships here are very senior, like for post, maybe ST7, 8 levels are what are mostly dealing with fellowships. In that case, you do need an MRCS. Especially for dedicated fellowships, I do think you need an MRCS. They're quite senior job applications. And for observerships, at what level, I'm not sure, because observerships usually are very junior, at a very junior level. So we do have observerships here, but they're notoriously difficult to get as an international medical graduate, because if you're not in a particular trust, and if you're not sent on an observership or a taster week from that trust, is very difficult to get. You need a consultant to recommend you. Yeah. So I would suggest it would just be easier to get a job, because there are lots of opportunities here for a job itself, and an observership is not necessary. So I hope that answers your question. Career in the UK after MCH in India. I think I've already answered this question. So it's just after an MCH, you're quite senior. You're already nearly a consultant in India. So it would be very difficult to start again from an ST3. So it might just be easier to come here, apply for a couple of fellowships in your area of choice, do some rotations, where be with a consultant, be in a particular unit for 2 to 3 years, sign off all your CESR competencies, write FRCS, and get a CESR consultancy. Can you name the book again for Part A clearly? Okay, sorry. It is called Raftery, RAFTERY. It's a textbook. It's a very old textbook for MRCS. I found that useful. Try it. If it's a very weird book, but if you like it, you like it. So it's just, if you can, I believe it's available online for download. So yeah, it might help. RAFTERY, Raftery. Degree. He's done a 5-year degree course from Kyrgyzstan. MRCS qualification mandatory or not? I'm interested in surgery only. Okay, fine. Yes. Oh, this is Kannan's related to Kannan's previous question. So he's completed a 5-year course from Kyrgyzstan and done his FMG. So if you're definitely interested in surgery only, then I would suggest, if you can crack the MRCS in the first or second attempt, I would always recommend the MRCS pathway. It would put you at a benefit, even if a small one. So if you can crack the MRCS based on what we've discussed thus far, if you think academically and in terms of a surgical skills wise, a surgical experience wise, if you feel like you're able to crack the MRCS, then I would definitely recommend that. Is ATLS in India developed by American College of Surgeons valid and helpful in the UK? Interestingly, yes, I did ATLS in India by the American College of Surgeons. I had the same doubt, and I have had people telling me no and yes. I have submitted the certificate in ATL. My ATLS India certification everywhere that I've been asked, and so far it has been accepted. Nobody's really questioned it. But again, most of the interesting thing about applications in the UK is nobody really questions your certificates. You yourself declare that you have ATLS, you have BSS, or you have CCRISP, and nobody really expects you to upload those certificates and say, nobody really says, no, this is not accepted. So I think, yes, an ATLS India should be accepted. Nowhere have I been denied the same. Where did you work in India, ma'am? How do you find jobs specifically in surgical department? So I worked in India. I worked in Kerala, Kerala Institute of Medical Science, KIMS, Trivandrum. Basically, I applied through a consultant that I knew, and I submitted my CV, and I had an interview, and I got through. So there are lots of hospitals where they need medical officers, or they need non-academic JRs. I believe, depending on where you're living, you can have lots of my colleagues during PG preparation also worked as non-academic JRs in different places. So I think it's just about contacting the HR department of a particular hospital, or if you know any consultants, if you can ask them to refer you to a surgical consultant, and they will speak to them. It's not a very definitive pathway, unfortunately, for non-training or non-academic JRs. Some hospitals, like say AIMS, JIPMER, and all, have dedicated non-academic JR posts. This will be seen on their websites. You can apply. But if you don't want to apply to those hospitals, then you have to approach the hospitals, the HR departments themselves, and apply, give your CV, get an interview, etc. How to get audits? Can you show us some examples? Okay, so like I said, here in the UK, audits are quite simple because they're usually in every department. There'll be several audits ongoing. You just have to sign up to one of them. You just have to express interest, and they'll help you choose an audit. But in India, it's a bit more difficult because a lot of hospitals don't really have a quality department, don't really have an audit system in place. So what we can do is, what I did is I spoke to my consultant. I told them, told my consultant that, okay, I'm interested in doing this audit. And I got in touch. Luckily, my hospital had a quality department. So I got in touch with them. And it's mostly about speaking to your consultant. So when you're not sure, you can always speak to your consultant and hopefully they'll help you. If not, what we can do is think of a common surgical topic, which is a very common topic. An example is, say, VTE, like venous thromboembolism prevention. So every surgical department should have a way in which you can prevent DVT or PE after a surgical procedure. And it's usually recommended. So a question would be, is that being adhered to in this particular hospital, in this particular department? So you can basically do an informal audit where you take, say, all the patients who underwent surgery in that particular 1 month, see how many of them really required VT prophylaxis, how many of them actually got it, and compare that to the national standards and give that, just do a tabulation, write a paper on that, not paper, like summarize your findings and show it to your consultant. And they will be able to give you a letter saying, okay, so you have done this particular audit. Even better is if you can present it in the hospital audit meeting or in the hospital, any meeting, and say, okay, you can present your findings, and what you can do is you can suggest an improvement. If you find that the findings that you found is not as good as the expected standards for that particular topic, then you can suggest an improvement. Say for VT prophylaxis, you can the intervention can be as small as just putting a poster saying, this is required. Have you done it? For doctors, or for in the doctor's room, or in the casualty, or in the wards, anywhere. That is an acceptable intervention, and then you can do a re-audit after, say, 3 or 6 months, and say if this shows any improvement. So basically, an audit is assessment of any particular aspect of the functioning of a hospital, and to see if that matches with the universal standards, and if not, what you can do to improve it. It's as simple as that. But it's very difficult in some hospitals in India because we don't usually do them. It's if you don't have a particular system in place who you can ask, then the bare minimum would be to do one like this yourself and get your consultant to, you yourself can write a letter, like I write a letter and get your consultant to sign it. Again, if you have a doubt in how that letter should be, you can go on to the oral side. Like I said before about the teaching experience, you can go on to the oral side, then access the self-assessment questionnaire for co-surgical training, and there'll be a section on audits, and under the audits there'll be a paragraph saying, okay, I have been involved in, or I've been the lead investigator in both cycles of a surgically themed audit or quality improvement project. You can copy paste the whole paragraph into a letter and get your consultant to sign it. So that is one definite way of getting an evidence for audits. I hope that answers your question, Srinivas. What pathway after MCH in India? So I've already answered that question. I hope that's clear. No problem. I have done my internship in 2 different hospitals with a gap in between due to COVID pandemic. How to approach this while applying for GMC? So GMC I don't think they would deny your application just because you have a gap, especially due to COVID pandemic. COVID pandemic is a good enough reason for anything. So I'm not sure how big a gap you're talking about. If it is anything less than 6 months, you don't really have to have a certificate or anything proving. So as long as you can explain your gap, you can definitely, the GMC wouldn't be too problematic about it. The worst case scenario is you would explain your gap and they would ask for certain evidences. So they will email you back saying, okay, there is a gap in so and so time. We need more evidence, or we need more evidence about what you were doing in that time. So you might have to say get a letter from somebody or from one of the hospitals saying, okay, because of this, the candidate was not able to complete his internship in one place. It is because of this. And you can upload that letter to them and it should be fine. I hope that is okay. Aditi is asking, I've cleared Plab, I have GMC license, preparing for MRCS Part A. I'm doing non-training job in general surgery. Amazing. Meanwhile, can you please suggest what all I can do in India to build my portfolio, especially some courses from where? Okay, definitely. Like I said, good luck for your Part A. And what you can do to build your portfolio is, for courses, I did basic surgical skills from the RCS. Like if you can just go on the RCS site, any of them, England or Edinburgh, and look for courses, they will show up as BSS, and they'll have routine BSS happening in several hospitals in India. You just have to apply for the next one. So BSS is one, ATL is one. Oh, sorry, non-training job in general surgery in India. Okay, perfect. All right. Either way, so BSS, ATLS, CCRISP. So care of the critically ill surgical patient. These three other courses that I did. CCRISP is not necessarily required at an SHO level. It can help. It can help, but it is more required for registrars. But either way, these are the commonly done courses, like courses that everybody requires. Then other things that you can improve your portfolio is, like I said, audit or quality improvement project, publication. So if you have done any research work, say case reports don't really count so much in applying for training. For training, original research really counts. So if you're working in general surgery, if you can ask your consultant if to do any one particular research project. If not a research project, what I would suggest is do an audit, a really good audit with your consultant, and publish that. So you have an audit and a publication in one go. So, if you can publish that, you have an audit, publication, present that in say any good conference in your local conference. You have audit, presentation, and publication in one go. That really helps. Then what else can you do? Teaching experience. Like I said, what you can do is speak to your consultant or the nursing officers in your hospital. Yeah, publications does have to be PubMed indexed, especially for training. For non-training, doesn't really matter, but for training, publication counts only if they are PubMed indexed. So if you can speak to the nursing officers there and arrange maybe a teaching session for the nurses, like say it can't be just one, it has to be say a session of 4, and anything like maybe IV cannulation or maybe about detecting early signs of DVT or anything, any teaching sessions. If you or not, you don't have to personally take the classes, you can arrange for other people to take the classes. So if you organize them and get that signed off or get a letter from your consultant or your hospital saying that you've done this, that's your teaching experience sorted. So things like this. I know it sounds like a lot of work, but it really will pay off in applying for jobs and in your training applications. I hope that answers your question, Aditi. How do you show the evidence for our operative experience in India for a registrar job? So there's something called an e-portfolio. If you can just Google e-portfolio on this thing, a particular website will come up which has basically spaces for you to like give logs for all the surgeries you've done thus far, and finally that you can summarize. Like in that website, they'll if you can click on summary of portfolio, it will show a page where all of the procedures done thus far or from a particular rotation or from a particular date period will come up, and then you can just print that out and give it to your consultant, and they can sign it, and give their registration number, and that is valid as or operative experience evidence. I hope that was clear. Just to say again, if you can Google e-portfolio or e-logbook, let me see if I can open that up here. Sorry, this is, yeah. There, this is the one. So if you can create an account on this, and you can start logging in, and that should help to create a summary screen, which you can download and which you can print out and ask your consultant to sign, and that counts as operative experience. I hope that answers the question. Sorry. Okay, yeah. So with MRCS, where to apply for fellowships? I'm not sure what level of fellowships are you talking about? Post-training fellowships, or if Dr. Pavan can elaborate which level you're asking about, that'd be great. Thank you. Aditi again asked, I'm also doing a certification course of surgery for 3 months. OC Academy in collaboration with Royal College of Surgeons of England will be adding to my portfolio for surgery and non-training job. Definitely, like great job. Any surgical courses there's a when you apply for a non-training job, there's a section where you can fill in surgical courses, and any surgery courses that you do will actually help in furthering your portfolio for surgery, for non-training jobs. So I think, yeah, that would be great. But it's not necessary in these courses may not help in your training, because for training, you have very strict criteria on what they're looking for, and only certain specific courses will be accepted. These courses may not, but in your non-training portfolio, definitely it will help. We're doing only MRCS Part A help for non-training jobs in surgery after Plab. Not really, because for non-training jobs, the question is whether you have MRCS or not. And if you're applying for an SHO job, MRCS is not necessary. It's not absolutely necessary, but if you have MRCS, you will have an edge over the non-training. Not edge over other candidates, but it's not absolutely necessary. And I don't think Part A alone will really count for much. The question they'll ask is, do you have MRCS or not? So if you say no, then probably not. I have not cleared without FMG if you're eligible to attend MRCS exam. I'm actually not sure about this, Kanan. Kanan's asking if somebody is eligible to attend the MRCS exam without FMG. So my recommendation or my advice to you would be to go on to the, like I said, WDOMS, like World Directory of Medical Schools website, and it's there in my presentation, and see if your parent college from where you did your MBBS in Kyrgyzstan, if that is accepted, and if that is not accepted, then you have to contact the RCS directly. If you can email them, their contact details are available on the RCS website. But if it is accepted, then I don't think you'll need your FMG. You can directly apply for an RCS with your MBBS certificate from that university. So again, to summarize, you can just go on WDOMS, World Directory of Medical Schools website to see if your Kyrgyzstan university is on the list of schools. If it is, you can directly apply for MRCS Part A with that certificate. If not, then you'll have to email Royal College of Surgeons, so whichever RCS you're hoping to apply to. I hope that answers the question. Katyani said, thank you very much. Wonderful session. Clear all doubts. Thank you so much, Katyani. Katyani, sorry, I misread your name. And also give inputs which have proven to be super helpful. Thank you. That really means a lot. Yeah, so this is Mortimer Green. They basically do training for MRCS. It's really helpful. I did my Part B preparation with them. They really helped me with it. And Dr. Vinayachandran has constantly been a wonderful mentor for me. So I would really recommend joining them. So I'm sure you can speak to any one of the organizers. If you just speak to anyone from Mortimer Green, they'll be able to give you, help you with the membership. It's not a membership. I think it's a course for MRCS that you can apply to. Thanks again, Katyani. Aditi saying, where do I do BSS course in India? Will BLS and ALS in India by AHA also be valid? So BSS course in India, I did it from Symbiosis in Pune, but that's not necessary. Like, it doesn't necessarily have to be Symbiosis. Like I said, you can just apply. You can just go on to the Royal College of Surgeons, England and Edinburgh. Edinburgh RCS do a lot of courses in India. So if you can just type in the courses and events and courses section, I think on the RCS Edinburgh website, you can just click on that and search basic surgical skills, and all the upcoming basic surgical skills courses will be given online. Select, see which one is closest to you, which one is most convenient to you, and just apply. So I'm not exactly sure where specifically you'll get. One place that I definitely know is there is Symbiosis Pune, because I did it there. Yeah, it is available online on the RCS website, and that should be able to guide you. And will BLS and ALS in India by AHA be valid? I believe so. Like I said, I'm really don't quote me, I'm really not 100% sure, but my AHA certificates, if you say you have BLS and ALS, they don't really question where you got them from, and they don't really scrutinize you on that. So I think it should be valid. But like most of the trusts here will give you a BLS course nonetheless, irrespective of whether you have a BLS already. So it's part of your Statman training. Statman training is basically when you join a trust, or every year or every 2 years, you have to have your basic skills updated. And your trust itself will give you free courses on BLS, basic pediatric life support, etc. So for ALS, I think the HA one should be valid as well. Thanks, Aditi. I'm really glad it was helpful. Srinivas again said, oh yeah, thank you for the session. No problem. I'm really glad this was helpful. Are RCS courses available in India? Do you mean the RCS basic surgical skills course, or what courses are you talking about, Mohit? In terms of RCS, BSS courses, yes, they are available in BSS. CCRISP are both RCS courses that are available in India. ATLS, oh yeah, so BSS, yes, is available in India. They are available in India. Maybe not as frequently as in the UK, but I think yearly 3 or 4 courses are available. ATLS is not exactly, yes. START is available in Chennai. ATLS is not done by RCS, but BSS, CCRISP are done by RCS, and they are available in India. It's just about getting a slot. I have cleared, Aditi says I've cleared Plab. Oh yeah, this is something I've already answered. Yeah, no problem. Atif says super comprehensive session. Thank you so much for stating. Okay, yeah. Okay, perfect. Thank you. I'm really glad that you enjoyed the session. Thank you, and all the best to you as well, Atif. And oh yes, so post MCH. Okay, Pavan says post MCH, I did MCH plastics and MRCS. Where can I apply for fellowships? So to Dr. Pavan, so if you have done your MCH plastics, then I would personally, I can only give you my experience. You're very senior, I think, and I would really recommend it where I'm working now. It's a wonderful place. So plastics, the thing is, you have to have a major trauma center. Not how the system here works is there are trusts, and every trust will have one major center, and all of their plastics referral, like certain specialties, like super specialties, are available only in one particular hospital in that trust. So in my trust is my hospital, and so there are several really good hospitals here in the UK for plastics. like say St. George's, Guy's and St. Thomas, my hospital, which is Royal London. And I know from experience that my hospital is really good for plastics and the team is really good. So you can actually apply for fellowships there. How you can go about this is if you can go on to track jobs, and on track jobs you will have a place. I mean, when the surgical jobs open up, some of them will say micro fellow or post CCT plastics fellow, post CCT breast fellow. These, so when the job itself open up, you will see these headings when you're applying for, in their job description. So you want to look for names. I mean, want to see such jobs, or if you want to have a more dedicated search, when you sign up with track jobs, you can apply for. When you give the job search, you can specifically ask for, say, post CCT or consultant level or whatever. You can basically narrow down your search to include your level, so that only those jobs come up. So my suggestion is you can apply for fellowships on track jobs. They will give you up to a year or 2 years fellowship jobs, non-training, which actually will help. I would suggest that pathway. I hope that was that gave some insight, Dr. Pavan. We're doing only MRCS Part A Health Phenom. Okay, that's I've answered. Sorry, where can I do PSS course? Sorry, this. Okay, fine. So I think that. Okay, so Kanan says World Directory of Medical Schools is listed. Perfect, great job, Kanan. So in that case, you don't have to worry. I think you can directly apply for an RCS Part A application. Thank you so much, everyone. That, yeah, I hope this was useful for your time. It was quite extensive. I'm really sorry it went on for so long. Thank you so much. Okay, so Mohit again asked for tips for improving communication skills. For improving communication skills, there's no short way to go about it. Practice. So for MRCS, they don't really scrutinize you on your English grammar or your English the vocabulary, so don't worry about that too much. That is more something you have to worry about in your IELTS and OET. But for MRCS, it's more about how your non-verbal skills are. There are certain commonly used phrases like, okay, I'm really sorry. Like when a patient tells you something about something bad or something concerning to them, you can just say, oh, I'm really sorry about this particular thing, or I'm really sorry you're feeling this way. So the tips for communication is practice, and practice with somebody to give you feedback. So you might not be able to know how you are speaking. So one thing is ask someone to be there for you, ask someone to actually be the patient and give you feedback. Second thing is videos. Record yourself delivering a particular conversation, and see how you can improve. And definitely these courses will help you tweak your communication skills. So yeah, just give yourself adequate time to identify where you're lacking and work on them. That's my tip. Thank you. Yeah, I'm really glad this was a helpful session, and I hope I can see you all soon. And good luck for your MRCS, and hopefully we'll all, if you're planning to come to the UK, hopefully we'll get to cross our paths soon. Thank you so much, and have a good evening. I'm sure it's late there, and have a good night. Thank you very much, and I'm going to end the session now. Thank you.